renal artery stenosis or renal vein thrombosis. So the above three, which is less less vascular volume, less cardiac output, and systemic vasodilation is due to generalized reduction in tissue perfusion. But renal vasoconstriction is selective reduction in renal perfusion. Okay, so next would be the renal cause. Renal cause can be divided into glomerular, vascular, and tubulointerstitial. So the glomerular nephritis can be divided into primary and secondary. Primary would be Goodpasture syndrome or anti-neutrophil cytoplasmic antibody or SLE. The secondary causes would be infection or vasculitis. And the second one is vascular. In vascular, it can be caused by hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, DIVC, or malignant hypertension. And then the third one would be tubulointerstitial, and there's two main causes. First is acute interstitial nephritis. So acute interstitial nephritis is immune-mediated tubulointerstitial injury. Okay, and the main three causes would be drug, infection, autoimmune. In drugs like lithium, NSAIDs, or chemotherapy. For infection, TB, lepto, HIV, and for autoimmune would be SLE, sarcoidosis, and all. So for acute tubular necrosis, this is damage to the tubule cells of the kidney. So the main reasons could be renal hypoperfusion or nephrotoxicity. So in renal hypoperfusion, the main one could be a post-ischemic or hypotensive or sepsis. Nephrotoxins would be all the nephrotoxic drugs, mainly would be aminoglycosides, and then antifungal, and heavy metals, or ethylene glycol, or radiocontrast also. Okay, so that's for renal. So for post-renal, it can be divided into two, within the renal tract or extrinsic compression. So for within the renal tract, it can be stones, malignancy, stricture, or clot. For extrinsic compression, it can be pelvic malignancy, prostatic hypertrophy, or retroperitoneal fibrosis.
Okay, so I'll be presenting on the investigation part. So the purpose of the investigation, there are four. First is to confirm the diagnosis, to find the causes, look for complication, and also to monitor the progress. So to confirm the diagnosis, we look at the renal profile. And then to find the causes, we'll look at full blood count to look for any evidence of infection or reduced in thrombocytopenia or any, and also then the collagen screening to look for any anti-double stranded DNA in autoimmune causes, and subsequently urinalysis to look for any hematuria or proteinuria, urinary ultrasound, KUB to look for any mass, and also renal biopsy to rule out any RPGN. Subsequently, for the complication, we'll do chest X-ray to look for any evidence of pulmonary edema, serum electrolyte to look for any dangerous hypothermia, and blood gases for life-threatening acidosis. And then to monitor the progress, we'll do renal profile, ABG, and also chest X-ray. So this is the differences in the urinary profile in between the pre-renal and intrinsic renal failure. So as you can see, in pre-renal, there is no sediment. However, in intrinsic renal failure, there is tubular cell cast and also granular cast. For specific gravity is high in the pre-renal, while it's normal in the intrinsic renal. Sodium will be low in the pre-renal and will be high in the intrinsic renal failure. And for the functional excretion of sodium is less than 1% in pre-renal, while it's more than 1% in intrinsic renal failure. And for the urinary to plasma urea ratio is more than 20 in pre-renal and less than 10 in intrinsic renal failure. And for the urinary to plasma creatinine ratio is more than 40 in pre-renal and less than 20 in intrinsic renal failure. And urine to plasma osmolarity ratio is more than 1.2 in pre-renal and is less than 1.2 in intrinsic renal failure, and the osmolarity is also more than 500 in pre-renal and less than 400 in intrinsic renal. Okay, next I'll pass to Sharifah for the management.
Okay, so for management of renal failure, for pre-renal causes, we focus on fluid management as the causes is more to hypovolemia. And then intrinsic renal, we depends on the causes, such as if it's acute glomerulonephritis, we give glucocorticoid. For post-renal causes, we aim to relieve the obstruction. So management in acute renal failure is mainly supportive. So there are few um, managements for fluid management. The hallmark of acute renal failure is marked reduction in uric production. But however, there's exception for non-oliguric renal failure. We need to restrict the fluid. For pre-renal causes, like I said just now, fluid replacement is important. So and then other management includes blood pressure, and then tackle the hyperkalemia, the uremia, focus on nutrition, and also drug dosages. So for fluid management, it depends on either it is volume deficit